So welcome to this, fourth episode, Shilpa, of this series. So this is 101 Gynecology. Now, I'm fascinated by this because I think if you ask most people, menopause specialist, gynecologist, they might be forgiven for thinking, well, that's one and the same thing, isn't it? And quite clearly it isn't. So first of all, can you give us the definition? So our wonderful colleague, Dr Shilpa McQuillan, who is a former hospital gynecologist, she's now community gynecologist and menopause specialist. What is a gynecologist?
Well, that's a question, isn't it? So, yeah, hospital gynecologist is somebody who will see you for your women's health needs, but it's very broad. So we're talking right from things like managing with medical treatments that you can have for things like your periods, menstrual problems, things like pelvic pain. But then what a gynecologist also does in a hospital is that can take you right through on a pathway from kind of finding out what's going on with yourself, going through all the different treatment options, but can also operate. So a gynecologist may be somebody that you see that you may not need an operation, but there is that option of talking through. And don't forget, it's individualized. It's not always about what you should have. It's about talking through what all those different options are. Do you need medication? Is it just we watch and wait, or is there the option of surgery? So that's what I used to do as a hospital gynecologist. So what's a community gynecologist? What I love about community gynecology is it gives me that option of in the community of, it is literally what it says, providing women's health care. And it's an overlap because you have really wonderful general practitioners. I am a general practitioner who can do a lot of women's health advice as well. But having that extra knowledge of being able to talk all the different options and also having that referral pathway. So it provides that intermediate care between your primary care colleagues, general practitioners, your hospital colleagues, not necessarily needing to go to that route, but having that all-rounded providing care for your women's health needs as well as contraception needs. And then you mentioned, are they separate to being a menopause specialist? Well, I did all my gynecology training and I did an extra 3 years to become a menopause specialist as well.
Yeah, amazing. So one thing that I'm still sort of thinking, so does that mean, obviously, given in previous episodes, we've talked about things like genitourinary syndrome of menopause. We know that the urinary tract is geographically in very close proximity to our reproductive anatomy. So does a gynecologist look at that as well, or not?
So absolutely. So the beauty of gynecology is there's lots of subspecialties. You might have even heard of obstetricians along with gynecologists. So some gynecologists are still dual trained, so still doing obstetrics, so delivering babies, complicated deliveries and complicated antenatal care. So those people who need that extra support from a consultant in their pregnancy, or even pre-pregnancy, pregnancy, and then after pregnancy. And then gynecologists have lots of different subspecialties. So you mentioned your urology tract, so your bladder, your urethra is in close proximity. You can get urogynecologists.
Wow.
So what I love about gynecology is it is so broad, but it can fit in so many different spectrums. So you can have a gynecologist, you can have a community gynecologist, someone who really specializes in cancer care, so pelvic cancers. You can get loads of what we call MDT, so multidisciplinary teams where you work together. So you might work with a breast surgeon as well. So those people, for example, have breast cancer who have their ovaries taken out. So it's such a broad range of different specialties that can be brought in together as a term gynecologist.
And I think that's so important, having, again, had previous guests on talk about breast cancer. So Dr. Alison Macbeth and Alice Macbeth and Alison Duffy talking about actually how some of these very powerful treatments for breast cancer, so aromatase inhibitors, can actually cause devastating side effects in terms of genitourinary syndrome of menopause. So it's really important, actually, if we can connect the dots around that person and have as many people to understand how we can look after people, because it's not just the treatment, but it's the side effects of those treatments can be so debilitating for people that often, and these are not my words, these are other people's, those bits can really get missed out, and people aren't really necessarily helped as much as they could be with some of those ongoing side effects or symptoms from their treatment.
And that's why I love the fact that I've trained as a GP, I've trained as a gynecologist, and I've trained as a menopause specialist. You're absolutely right. It's having a whole rounded approach, isn't it? So when I see patients, I'm able to tell them what surgical procedures may be involved. But before you even get to that point, just explaining to them the risks and benefits of what and whether it is for them, and also what could be the side effects or what could be the result of that, how I can help support them. So I'll have women who come to me who, for example, are actually going for a hysterectomy, but obviously they don't know what's going to happen afterward, or if they had their ovaries taken out. So I'll have consultations just to discuss what the side effects and effects could be. And actually, let's also think about the menopause that might be created from that. Let's start your HRT before it gets to a point where you're having to suffer and wait for that. Let's talk about how we can make your recovery really good, get you in the best health prior to having that operation. And one might say, well, that's what a hospital gynecologist does. But this is where our time constraints really come into it, isn't it? Where you go and see a gynecologist for that one appointment, you don't necessarily have that continuity of follow-up. Same with a GP surgery, really time constraints. So I love the fact that I can have consultations where I follow these ladies up in all my different roles as well.
Well, that's why it's, you really are a bit rare in that sort of way, aren't you, in that you're offering all those three experiences but actually in one place, and that's vital. And I honestly believe a lot of people don't necessarily understand the difference between those roles, or maybe appreciate that they could offer different things to them. And so actually going to see one person who's doing all of that in a lot of ways shortcuts it, because you can actually have those richer, deeper conversations about what's going on. So okay, so let's talk
Nick,
about
I like to
Sorry,
I was just saying, I refer to it as a one-stop clinic, so where all your needs can be met in one place.
Exactly. So let's talk a little bit about, then we've got a few things to talk about. So when can you stop contraception? And actually, let's talk about something that people aren't talking about, which is vasectomy as well. So let's talk about those two things together, can we? When can you stop contraception? And let's chip into the topic of vasectomy as well.
Really important question, because there's some patients who will be on contraception for since they're teenagers, and coming around menopause, it's such a big topic now, menopause, and so they'll say to me, I've been on this for 30-40 years, I've not had periods with the type of contraception I'm on, so I don't know where I am in the perimenopause or menopause stage, but I don't want to still be taking this contraception if I don't need to. So there's a couple of rules. If I just, I'm going to break it down. So imagine if you're not on any hormone therapy, or you're using contraception such as condoms or diaphragms, so something that doesn't have hormones in. For those people, if you're under the age of 50, we would say you need to use contraception for 2 years from the point where your periods stop, and then you can stop contraception. Why is that? Because in our previous episodes, Amanda, we've talked about how much your hormones fluctuate. And so you really have to be confident that that you're not still having continuing ovulatory function. And so we say that 2 years is enough time from stopping your period. If you're over the age of 50, your ovarian function starts to decline more. And so you can say that after a year over 50, if you haven't had a period, you can stop contraception. And so that's where people know hormonal contraception. But people are on combined, aren't they? They're on things like estrogen and progesterone pills. So what do you do in that case? So for those ladies, we say to them, stop that at the age of 50. And there's 2 reasons for this. The first being, I've talked about this before, our risk of stroke increases as we get older. And so we tend to tell people, don't be on estrogen contraception over the age of 50, because it can increase your risk of stroke. Why is that? Because estrogen in a contraceptive pill is synthetic, and it is taken through the mouth. When you go through the mouth with a synthetic pill, it goes through the liver. Liver is where your clotting factors is made, and that's why it puts us at increased risk of stroke. So stop any contraception with estrogen over the age of 50, and then use progesterone types of contraception. So they're things like your Mirena coil, progesterone-only pill, things like your depot injections. Implants, sorry, I forgot implants as well. So contraception, if you're not needing any contraception, you can see what your period's doing and then follow the rules over 50 of waiting a year from your last period, or move on to a progesterone contraception. So then what do people do if they're on progestogen contraceptions? Well, this is a little bit easier. So how many women do we know that are on Mirena calls who haven't had periods for years? And they want to know, do I still need contraception? So again, under the age of 50, I would say continue your contraception because of how fluctuating the hormone is. Or you can wait till the natural age of 54, which is where we say you probably can confidently say you can stop contraception. And so if you, for example, we due your Mirena to be changed at 54, you might think, well, now I don't need to because I'm only using it for contraception. So you would stop it naturally. But if you're over the age of 50, and let's say that this is a typical scenario, well, I'm due to have my Mirena coil changed. I'm 52. I don't really want to go through that procedure if I'm only using it for contraception. What can I do in that scenario? So in that case, you would have blood tests. So this is where blood tests are useful. So you would have 2 follicle stimulating hormones to test whether or not you're still ovulating. So that's the test to see if you're menopausal. 6 weeks apart at least. And if they're showing that you're menopausal, we would still say wait a year from there.
So can we just clarify because I know what we would see in those follicle stimulating hormone tests, but what would we see? High levels or low levels?
High levels. Yeah.
Yes.
So high levels indicate you're menopausal. So we say around the level of 30 is what we say. But and many people will only have 1 blood test done. Why do we say more than 1 and at least 6 weeks apart? Because of how much it fluctuates. So I very, very often see women get a high level, but then their level's normal, and low again. So you need 2 6 weeks apart high levels. And even then we say wait a year because of how much it fluctuates, and you can still get that chance of getting pregnant.
Yeah, and that happened to me. And stress, again, I know I keep saying playing the same record, but if you're going through a particularly stressful period, as we will be in midlife, financial constraints, caring for elderly relatives, children still at home, empty nesters, all of these things can dramatically cause our ovaries to kick in and kick out in terms of functioning, and people mustn't underestimate that. And we also know things like getting COVID vaccinations. I went nearly a whole year, Shilpa, without any menstrual bleeding, and then 2 weeks after my COVID vaccination I got a bleed. So of course I reported that as a yellow card, but the reality is I was back round again then to counting another 12 months. But I was also quite concerned about that bleed, because if you're not having bleeds, any sort of sudden bleed should be investigated. But so it's really, really important that we do sort of know what we're getting into. And what I quite like is the positive narrative, because we hear such a negative narrative around you don't need blood tests, you don't need blood tests. I actually think blood tests are quite helpful at various stages as you go through your menopause, either to check that you're absorbing or not absorbing, like we said in a previous video, but also just to sort of back up what we might be seeing, symptomatically, to get that clinical reference point as well can be really, really helpful. So coming on to vaginal bleeding then. So when is vaginal bleeding abnormal, Shilpa?
I forgot to talk about vasectomy, so we'll come back to that if we get a chance.
Yeah.
So let's talk about vaginal bleeding. So we've said, haven't we, perimenopause, years before, can occur years before the menopause. And menopause is a retrospective diagnosis of when your periods stop 12 months 12 months after your last period is what you're classed as menopausal. Now, when is vaginal bleeding abnormal? It's not just around menopause, but I'm using this as an example because many people get really erratic bleeding leading up to that. And I get not only from patients, but other clinicians asking me, well, how do I know actually what is normal? So whatever stage in your life, I would say, is if it's abnormal for you, it still is worth a conversation with a health professional. So if you're used to having monthly bleeds and then that changes, I still will have a conversation to see, is that normal? And what I will normally say to people is wait 3 months. So if your periods suddenly stop and there's a chance of being pregnant, don't wait 3 months. Don't, take a pregnancy test. But if you notice, like you say, Amantha, stress is one of the most common things, changes in weight, things like stress, leave it 3 months and see if it regulates itself. If it doesn't, have a conversation with a doctor. So normality to your own cycle, more than 3 cycles, I will say that needs a conversation. What else is abnormal? So bleeding between your periods. So if you're having regular periods, start to get bleeding in between that. Well, why are you getting bleeding in between that when you're used to regular periods? And there's lots of reasons for that. Hormonal is a very common cause, but also is anyone examining you and checking why are you getting bleeding that's not cyclical? Because, and I always use the anatomy way to say, right from the vagina through to the uterus, through to the ovaries, could you have a little lump? Could you have a polyp that's sitting on your cervix? Could you be having bleeding just when you're having sex because there's contact bleeding when you're hitting the cervix? Again, can be normal, but there could be a little polyp sitting there that you're not going to know till someone's examined you. Have you had your smear test done? Is that up to date? Because obviously we know cervical changes or cancer or precancerous cells can cause abnormal bleeding. What about infection? Infection's another really common cause. And I don't necessarily mean STDs, because I think a lot of people worry, don't they, that you're suggesting they've got an STD if you're suggesting they need swabs. But no, even things like thrush, bacterial vaginosis, these are just some of the things that can cause an infection. And unless someone's examined you, done those tests, they're such simple things, but also the most common reasons to get bleeding after sex or in between your periods. So even the simple things need to be really ruled out. And if we rule those out, then you start thinking, actually, do we need something like a scan to check for polyps in the womb? That can cause irregular bleeding. We know fibroids tends to cause cyclical bleeding, but you can still get, extreme heavy periods that change, become longer, more heavier, again, changes to your periods. You might need a scan at that instance. And then things like your ovaries can cause changes. Now, changes to your ovaries, things like cysts, don't tend to give you vaginal bleeding, but I never say never, and especially in postmenopausal women, any changes like that, you can get, cysts on your ovaries, things like endometriosis, again, typically presents with heavier periods or bleeding regular still for your period, but you can never say never until, and so systematically work your way up the body is how I try and describe how to investigate that.
Yeah, and that was me a year ago. So I presented at my doctor with really dull pain, lower abdominally. And now, of course, I spend a lot of time sitting in my office, Shilpa, and I've got terrible posture. I've been to the gym today, so I've got better posture. I've got terrible posture. I'm constantly slumping. And so I was sort of convinced myself, I just think I've just got terrible posture. But I didn't have any bleeding, but I just had a dull drawing sensation, a bit like if you're having your period. And I was like, that just doesn't feel right. And you can't do this job and not practice what you preach. So I made an appointment to go and see my gynecologist. And it was interesting because I felt I always also had like a urinary tract pain. I felt like I, had a urinary tract infection. I wasn't showing any sort of symptoms. Nothing was showing up in the tests, in the urine tests or anything like that. But anyway, I went and I did have a scan, and it was probably, I think I might have said this before on other podcasts, it's the only time I've actually ever cried. I'm quite a stoic person, and I have been about my menopause, but it's the only time I've ever cried in the 16 years that I've been perimenopausal. And it was because my consultant decided to look at my ovaries, and she could actually see a cyst in the ovary. But the saddest thing was the other ovary had shriveled to almost invisible. And it was in that moment I knew my chances of having another child, that was gone. And that's really what we're talking about here, aren't we? We're talking about a depleting number of eggs in our ovaries, which is what dictates those menstrual cycles, whether we, get one without an egg being released or we get one with an egg being released. It's all determined by the number of eggs sitting there. But actually what happened was that cyst was actually quite big, and it was causing that pain, and it was radiating in referred pain. And then about 8-10 weeks later, I was asked to come back, and it had shrunk. So it was really reassuring, because actually these things are floating, aren't they? Ovaries are literally suspended. They're floating around anatomically. So of course, any sort of pain like that, of course, if it's, you've been down the gym and you've exerted yourself, chart things. And that's the other thing I was going to say in response to what you said there, which was really helpful, is, there's so many apps there now, isn't there, that you can document your cycle, you can write down any additional points that you want to. It saves you having to remember it, because we all know what it's like when you've got that really short amount of time with Dr Shilpa, and she's had a lot to deal with, and you're not really sure about what you should be saying. Actually having that app can be really, really helpful. So
yeah, Well, I think changes for you, I've said about any in-between bleeding, but the other thing to be mindful is you could have periods regularly, but if you suddenly get really heavy flooding, so they're still regular, or you become anemic, again, that needs investigating because that's really abnormal for you. It's causing quite a significant, what we call systemic symptoms, where, it's affecting your heart rate, it's giving you shortness of breath, that is a real change to your body that requires looking into. So it's not just the irregular in between bleeding or after sex. If you have really, really sudden or extreme changes to your periods as well.
Yes, and there's another episode actually on our YouTube channel, which is an amazing lady called Catherine Neenan, who talked about who very nearly collapsed in her doctor's surgery. She'd had an episode of flooding and then had another one quite quickly, and she really just lost such a lot of blood volume that are you okay, Shilpa?
Sorry. Just goes to show these are all recorded. Things do happen to doctors as well.
Exactly, but we just checked that Dr. Shilpa's okay. Okay, brilliant. So what I heard there was know your normal, which is really important. Know your normal, and then go from there. But can you tell me then? So now this is the bit that might frighten people, and we know that actually it's nothing to be fearful of. But when you are there, when you have got your feet in the stirrups, and you go to see Dr. Shilpa, and she puts that very bright light on. What are you looking for, Shilpa? So talk us through briefly, if you can. What are you doing in that moment that's really helpful to the person?
Yeah. Medical school, we're taught look, feel, move. So the first thing is looking, and it sounds so simple, but it's so important. So you wouldn't believe how many people I see that have had bleeding, and this is for an ultrasound scan, but we haven't even looked at their vagina yet. So the first thing you want to do is just look. And why is that? Because even changes like vaginal vulval atrophy can cause bleeding. So just by looking at the skin, are there any skin changes that can cause some of your symptoms? So, we've talked about in previous episodes about itching. Don't presume it's thrush and go over the counter, to the pharmacy. No. Get a gynecologist or get your doctor to have a look. So we're looking at skin changes. Some skin changes, you won't believe, some moles. Can you believe, did you know that you can get moles on the vulva, and actually some of them are actually skin cancer? And this isn't to frighten, you said this, it's not to frighten, but it's just to make people aware that just by knowing your own anatomy, get in a mirror, have a look down below. Why am I itching? Is there anything I can see that I can highlight to my doctor? And so that's what I will be doing. The first thing, I'll just be looking, hands-off approach looking. Are there any skin changes? Is there any bleeding? Obvious sources for this. Is there any discharge that looks abnormal? Discharge is one of those things, again, we were going to talk about, because everyone is different. And is it a change in you? So is there a smell to it? Is there a change in color to it? Is it watery? So that's the kind of thing I'll look at. And then we will use, potentially I'll do an examination. So why do I do a thorough examination? And what I mean by that is you're putting one hand on the tummy, one hand in the vagina. Why do I go to the extreme of doing this? Because not everybody does that. Because what you're demonstrating by doing that, firstly, by feeling both from the outside and inside, you're seeing if you can feel any big masses. Now, I'll be very honest with you. I've been a gynecologist for a very long time, and it really takes quite a big mass to be able to feel if you've got a big ovarian cyst, or, sometimes you'll feel fibroids. But not being able to feel it doesn't mean you shouldn't therefore go and get more investigations, because it's quite rare to feel it. But what you're also judging is the patient in pain? When you're doing that, where is that pain? Be a cyst, like you were saying, Amantha. Have I got a cyst? Is that what that pain is? Because I'm feeling something, in the sides of my tummy. Is there pain there? Why else I do it? And we covered this in our podcast, didn't we, when we talked about cervical screening, how important. I'm looking to feel where that cervix is. Firstly, can I feel any polyps or anything? So I use a small speculum, because I'm finding out where someone's anatomy is by doing that, instead of blindly trying to do this with my speculum. And also, if I can use a small speculum, being a woman, and when you get these things done, you really appreciate when someone uses a small speculum, because it can make the world of difference to people. But you're not going to know if you can do that unless you know where their cervix is, and how far away it is to know that if you can use it. So I'm doing it for the purpose of looking for pathology. So putting this patient at comfort and seeing what are my tools that I might use and are they appropriate? And am I doing it properly, or am I just, blindly doing this to somebody and poking around? So that's what I'm doing when I do that. And when you look in the speculum, then I'm looking at the cervix, and is there any bleeding? Is there any contact bleeding when I touch it? Anything that looks a bit suspicious, I might want to refer, even if they've had a smear up to date. Remember, there's 3 years in between that time period. Anything can still happen. So if you're getting any abnormal discharge or bleeding, it might need referring.
Well,
and that's what I'm
as
doing.
luck would have it, look what dropped through my door this week.
Oh.
It's my time. I can't believe how quickly it's gone. I've had an invite this week to go for my cervical smear, and I'm pleased to say my last time, because I was able to say to the person, please use a small speculum because my cervix is in retrograde. It points back. I know how it's doing. And because they listened, and because I sort of must have come across as quite informed, it was a complete breeze, honestly. And so I want, thanks to all the consultants and people who've come on my podcast, I've gleaned so much knowledge. I was able to advocate for myself. So, it's important that people do that. And actually, one of the things that helped me most was when you insert a tampon, if you use tampons, you'll get a sense of how your cervix points at various times. So that can be quite helpful. If you know that you have to put it in a certain way and it goes back, that can be quite helpful when you're talking to people who are about to examine you. So just drop that in as
absolutely. And you mentioned the bright light. This can be a frightening, something as we do it so flippantly, don't we? These examinations every day in, day out. But actually, it can be quite uncomfortable and quite scary for a lot of people. And I will actually say to people, if you want to bring your music, bring it. If you want me to turn the light down in the room, just so I've got that lamp on. And if you want to bring a friend to hold a hand, whatever gets you through that examination. We've all been through personal experiences of things that we've had to deal with. Some people have gone through gynecological problems. And so I would say, I have real sympathy for people, that the more comfortable you can make it for somebody, obviously, the more likely it's going to succeed, the procedure, that whatever you're doing. But also, we've talked in our last episode about not causing trauma that ends up psychologically causing trauma and other problems, later on.
And I think that's really important. One thing my dentist and my gynecologist do brilliantly is they tell me what's coming. Don't know why I mentioned my dentist, but that's an orifice as well, isn't it?
I have to get the right orifice.
Yeah, exactly. Yeah, he always gets. Yeah, don't you worry, it's fine. But what I find really reassuring is they tell you about what's coming. And what I particularly liked about my gynecologist is she said, "Okay, in a moment, what I will be doing is X, Y, and Z, and then I'll tell you what I'm going to do after that. Is that okay with you?" And so reassuring. Because actually you don't want to feel like that, because you are vulnerable, aren't you, Shilpa? You are completely vulnerable in that moment.
You're
probably really frightened. So actually to have someone say to you, listen, I'm with you, and we're going to do this together, and someone showing that compassion to you is hugely important.
It's a feeling of out of control. If anyone's had their legs abode, whatever it is, having a delivery, having a baby, having a smear test, whatever it is, having fertility treatment, having your legs abode is not the nicest thing, let alone someone then putting something. And it's that feeling of out of control. So I often say to patients, it might be, if I'm doing something sterile, make sure you don't touch the sterile field, but feel free to put your hands on your lower tummy if that gives you comfort.
Reassurance,
Because when you've got your arms up here and your legs up there, it can be, can't it? It's just you feel so out of control and not knowing what's going to happen.
Definitely. And we don't want people holding on to any sort of trauma or any newly generated trauma. So I'm just looking at my notes here. So obviously it's the perfect time to take things like swabs and literally going around, and those will be all cultured up, and we understand all of that. I mean, talk to us just very briefly then about two things: discharge, when it's normal or not normal, and things like burning sensations. I mean, not burning sensations, burning questions that other people might think of. Have people asked you things? So talk to us a little bit about the discharge, and then are there any other questions that we should be answering in this session for people who might
discharge?
Be...
Discharge is one of these things that's very individual. I always say to people, again, any changes to your normal discharge, it's okay to ask questions. Now, many people don't realise that discharge is completely normal. I'll start with that. because a lot of people will contact me, you know, and young patients will say, well, I've got this really clear discharge, and it's all the time, or I'll get it when I'm ovulating. They don't realize that it's actually normal to have discharge. So one of the things I will say is make sure, you know, is there a change in smell to your discharge? So offensive discharge generally means there probably is an infection going on, or something going on. You know, is there a change in the color to the discharge? You know, a frothy white, you know, a frothy discharge, green discharge, that's a change from your norm. Again, that can be abnormal. And even when you're older, can you believe? And again, this is where my gynecology experience comes into it. Clear discharge, even in a postmenopausal woman, can be abnormal and a sign of ovarian cancer. And a lot of people don't realise that. So I've had ladies who've had persistent, you know, vaginal discharge, clear discharge. It's normal, it's normal, it's normal. Never had a scan, and actually have had either ovarian cancer or the tubes, the fallopian tubes. You can get something called hydrosalpinx. So hydro being water, so it feels like it's basically enlarged, like water enlargement. So the tubes get bigger. In someone who's postmenopausal, that needs to be investigated. And actually, things like that combined with discharge absolutely could be a sign of something like ovarian or fallopian tube cancer. So it's not to say that everyone...
How would they know the difference then, Shilpa? Because obviously, like watery discharge, also we know if you've got vaginal atrophy of any kind, you can get that exudate, extracellular liquid or intracellular liquid coming out. So people say, well, I'm moist, I'm wet, it's not a problem. How's that different to what you're describing then?
So this is where it gets me back to making sure someone examines you and not presuming and having those telephone calls saying I'm getting vaginal discharge, someone seeing that you're menopausal and just presuming. It's examining, you know, in the vagina. So if you're getting persistent discharge, so imagine if somebody postmenopausal came with some clear discharge. I'm not going to presume they've got ovarian cancer, but I've treated them for vaginal atrophy if I see that there's anything that looks like that. Or I've given them treatment. Despite that, you're just getting persistent, lots and lots and lots of discharge. If you're postmenopausal, that really does need investigating. And I would rather be a safe doctor in someone who presents with 3 months of persistent vaginal discharge postmenopausally and get a scan than not do that and it not be okay.
Yeah, and I think that because that would be quite a difference, you know, usually for postmenopausers, you know, it's the opposite, isn't it? That there's not enough lubrication, and so that would be quite different then for people. That would be quite a marked difference, wouldn't it?
I mean, but you're absolutely right. Some people don't have dryness. They have the opposite because of inflammation cells. Inflammation cells cause white cells to be reduced and you can get secretion. So absolutely, it's not to say everyone with clear discharge postmenopausally needs to worry about that. But if it's persistent and lots of it, despite, for example, treating, you've presumed it's vaginal atrophy and treating, and that's not working, it's better to be safe and get an ultrasound scan just to be sure at that stage.
Yeah, and that's why it is important to keep up with your regular things like cervical screening, isn't it? And that's the whole thing, you know, screening, you know, it's not always a diagnosis, it's just checking everything's okay, because that it's a small area that's been looked at. But actually, that's why knowing your baseline, knowing any differences, taking a vested interest, it is an investment in your health to actually be self-aware. So, you know, to do that. And actually, sometimes that can be helpful with your partner as well. Our partners, you know, can be really helpful in noticing things about one another. So that can be really useful as well when we talked in our intimacy section, didn't we?
Well, you asked me what kind of question might I think of that somebody might ask me, but I would say screening and even including breast in that. So I always call breast cancer the sixth gynecological disease, because when I counsel patients or if I do education talks, I always include about breast cancer, because and this is men and women, but it's really important that all these like you say, those screening tests you're aware of and you know your own body. And I'll teach people how to do self-breast exams, how to look at their vulva, what things to look for, like you say, discharge, what to look for, abnormal bleeding, pelvic pain, you know, when is that ovulatory? When does that become abnormal? These are all the things that I will teach to people. But, you know, I even did a talk for school sixth formers the other day. And it's not just about menopause, as I said to you, you know, gynecology healthcare starts from the beginning. And I showed them a load of pictures of vulvas and said to them, this is just to demonstrate to you everyone is different. You know, and you wouldn't believe how many people I get, you know, come in saying that they think their vulvas are abnormal, that they want to have their vulvas cut, you know, which is a form of genital mutilation.
Absolutely.
But these are kind of things that I then demonstrate and say, look, everyone's so different. It's fine. And seek support if you're worried that you think something's different that it isn't.
Yeah, absolutely. And I've just it's just reminded me on our ethnicity episode, you know, those cultural norms also extend to the breast, you know, and how we perceive the breast. You know, for some cultures the breast is very revered because it's that life-giving anatomical part of our body. For others, it's, you know, there's an element of covering up and, you know, possibly shame in some circumstances. But actually, again, there was a beautiful account on Instagram called Asian Supernovas, and I just started following them. It's absolutely brilliant, and they are bringing the conversation about breast cancer out, so that we can talk about breast cancer. We can talk about, you know, if your nipple's inverted, if you've got lumps and bumps, if you've got you know, all the symptoms that we know about. It's so important that we, you know how to examine ourselves, know what good breast health looks like, feels like, most importantly, and how we can do that in a way that makes us feel safe, makes us feel reassured, and to encourage our friends and other women around us to actively, you know, like, and what I love now, modern day technology, you can have a breast check reminder ping up on your phone.
Yeah, absolutely. And you've also brought another good point up, is that because you brought up the ethnicity thing as well, but everyone's skin's so different. So actually, something like skin cancer on your vulva might look very different in somebody with white skin to someone who's got very dark skin. And sometimes it doesn't necessarily present in the same way. It might present with dryness rather than a lump. It might present in bleeding rather than a color change. Again, with the breasts, you know, I've put on a recent on my Instagram, but I chose specifically a picture that showed different coloured breast rather than just one, because, you know, certain symptoms might not show as clearly on one breast as they do another. So it's really important to know your own body and be vigilant, not just breasts, your vulvas, everything, you know, or down below your whole skin. And a lot of people, which also brings me on to, can't believe when they get diagnosed with things like vulval cancer, vulval skin cancers, weren't aware in, for example, Asian backgrounds, that they could get skin cancer, because they've always thought because the melanin protects you, and so you can never get skin cancer as being an Asian person, and that's not true at all.
No,
So it's really
so
important
true.
we're very aware of this.
Exactly. And one thing that I sort of think is actually to backtrack, you know, it's never too early to have these conversations with our children. And I talk about this all the time with my daughter. But one of the easiest ways is if you just look at your own lip colour and look at the variety of colours, textures and tones in your lips, that tells you everything you need to know about how important it is to know the other parts of your anatomy equally well, because the colour differentiation in itself can be alarming if you don't know that you might have colour differentiation, you know. So it's really important. And one of my concerns is possibly sort of younger generations now sort of almost are, you know, don't know what to do, so they don't do anything. And I think we do really need to encourage girls, boys, you know, transgender, cisgender, everybody to know you're normal and to bring that conversation forward, because there's amazing people like Dr Shilpa and her other amazing colleagues who are really just ready and waiting to help you. So it's like we need to just get rid of that.
I mean, I teach my 3.5-year-old the actual anatomical words of penis, vagina, you know, and people might find that controversial, but if I teach him the correct anatomy now, there's not going to be any taboo about it. And he's going to have an understanding, and he'll have a partner one day that, you know, I'll make it sure it's important that, you know, so I had a patient the other day who said, my husband knows my breast better than I do. Right. Well, then they can be aware to look out for things, can't they? And the other thing, just to bring on also briefly, you said about it teaching school kids. I took my vulval anatomy model with me with a smear test and a little speculum. And afterwards, the girls all came and looked, and I showed them how it happens. And most of them, I kid you not, said to me, I didn't realise it was that little. I didn't realise it was that quick. That makes me feel a lot better. So they're 18-year-olds.
Yes. And we're preparing.
Visual.
So one last thing that we didn't talk about, but let's talk about it super briefly, vasectomy.
So why I wanted to bring that up is that when you're talking about contraception, one of the things that gets forgot about is we talk about long-acting contraception, like things like coils, like things like implants. But I just wanted to bring out about this is where, again, communicating with your partner, a lot of people forget to talk about vasectomy as an option. You know, it's 99% effective. It's an outpatient procedure. I'm only throwing it out there because we were going to talk about contraception. Maybe we'll do another one on this, but we were going to talk about contraception. I just don't want people to forget that that is an option. And, you know, if you're going through lots of period problems or you're going through lots of issues, let's not forget there are two people who potentially could help sort out the contraception issue.
Exactly. It does not fall to the person with female anatomy to sort out contraception, just saying. You know, and we hear a lot of that in that narrative. And so, Shilpa, just very quickly, can vasectomies be reversed?
Not on the NHS.
But they can be.
Yeah, I mean they do in America, but it's not available, and actually less and less so it's available on the NHS. You know, often you have to apply for individual funding to get it done. But there are lots of, you know, there are obviously, it depends. Again, this is postcode, isn't it? But it depends on where you're based.
Yeah. Okay. So that's really, really helpful. So Shilpa, just before we wrap up, then obviously, if it was me sat watching this, I'd be like, oh my gosh, let me write that doctor's name down because I'm going to be in touch with her. Do I need to live in Berkshire, or is it not a postcode lottery? Can people access you if they don't live in Berkshire?
Yeah, I mean, obviously we've talked about, I'm an NHS doctor as well. I'm an NHS doctor for Oxfordshire and for Berkshire. And then I've got obviously Berkshire Menopause Clinic where I do virtual appointments. I have really honed in saying that if you've got something quite worrying, examination is absolutely important, but you know, people do travel. So I have a clinic that people do come to, or at least have an initial consultation virtually. I've had somebody from Cornwall the other day speak to me about their gynecology problems because they were recommended, and they found that really helpful because it gave them the tools then to go to their GP armed with the questions, and we you know, she downloaded my symptom diary, and then it gave her that initial step to do that.
Excellent. Well, that is brilliant. So I think that's really helpful. Hopefully people will know what the difference is between a gynecologist and menopause specialist, but actually they don't need to worry about that because you're both. So for now, Shilpa, that's our 4th episode done. And what people have got to look forward to in the last 2 episodes are endometriosis and PMDD and severe PMS. So for now, Shilpa, thank you so much for your time.
Thank you.